Right.
Yes, sir. I have the presentation.
Good. So good morning. We will have another session of OSCE type presentation. Today we will have some discussions on specimen instruments. And again today with us will be Professor Ramanuj Mukherjee, who is Professor of Surgery at Arjigar Medical College. So the volunteers who have already taken the responsibility will come up. And as I already said that these are all very specific question and specific answers. So don't loiter about more things. Whatever is asked, you should answer that. And at the end of this set question, we may have some discussions. Okay, so that maybe that the question comes exactly in your OSCE may not be the same three questions shown here. So we have some more discussions at the end of the question already set. Okay, so Milind, you start screen sharing. You can.
Yes.
Have decided now will be the first, second, third, fourth, sixth.
Yes, sir. Yes.
Okay, fine. Start.
So is the screen visible?
Yes.
So is Dr. Bharat P. Has Dr. Bharat P. joined? He's one of the volunteers. Dr. Bharat.
It's already 8, no? Yes. 8-2.
Yes, so he's not joined yet, sir. Dr. Kumar Gaurav. Has Dr. Kumar Gaurav joined?
Yeah. Follow the time, na? We are starting in time. Why not people should join in time? No, someone from MRB start.
Good morning, sir.
Good morning, sir. Good morning, sir. Good morning, sir. So Dr. Ganesh is
some audio problem.
Audio, here we go. Powering on.
Hello, sir.
Yes, sir. Ganesh, sir, you're audible.
Sir, shall I read the question, sir?
Yeah.
A patient underwent neck surgery and the specimen is shown. Identify the type of operation done.
Yeah.
Name any two. Sir, shall I tell the answer, sir?
Just start. Keep it the first. Yes.
Sir, total thyroidectomies. Name any two indications in benign condition that require this operation.
Why do you say it is thyroid? What makes you feel that this is a thyroid specimen?
Sir, the shape of the specimen seems to be like thyroid, sir. It seems to be having like two lobes and the isthmus connecting the two lobes. Yeah. And that's me.
So it's a classical butterfly staped
shape
with appearance of nodules on the surface. Okay. So this is looking like a thyroid only, having two lobes on the isthmus. Okay, fine. Name two indications in benign condition that require this operation. Yes.
Sir, toxic multinodular goiter.
Yes.
Graves' disease, sir.
One is diffuse toxic goiter and one is toxic multinodular goiter.
Okay, sir.
Good enough. It may not be mentioned toxic. Even in a multinodular goiter also, it's a total thyroidectomy.
Yes. Name any two histological types.
So I think it's a good answer. Toxic multinodular goiter and diffuse toxic goiter or Graves' disease. I think it is acceptable. Okay.
Name any two histological types associated with poor prognosis.
That means this is in addition to the malignancy.
Yes, sir.
Yeah.
If in case of malignancy means like medullary thyroid carcinoma, anaplastic carcinoma, followed by follicular thyroid carcinoma or arterial cell carcinomas.
Two histological types you just clearly say.
Sir, medullary thyroid carcinoma and anaplastic carcinomas. What is the additional structure that may also be removed if the pathology was better at type 5 on preoperative FNAC? Sir, if type 5 means a papillary carcinoma thyroid, so I would like to remove the nodes and involvement of the strap muscle is there, and I will remove the strap muscle.
You mean type 5 is a diagnosed malignancy?
Sir, suspicious of malignancies.
Yes. Suspicious of malignancy.
Sir, In case of suspicious malignancy, if the patient has a family history of thyroid carcinoma or prior radiation, I would also like to remove the nodes prophylactically. And if the thyroid is involved in the adjacent strap muscles may also be required to be removed.
No, if it is basically a type 5, then it's not the strap muscle that is to be removed.
Okay, sir.
What you can add is a central neck dissection.
Restriction.
Okay.
Okay, sir.
Ramanuj, you can have some more discussion on this.
Right. Now, to begin with, you said this is the total thyroid specimen. Okay. What is the difference between total thyroidectomy and near total thyroidectomy?
Sir, in total thyroidectomy, remove the entire thyroid. In near total, remove of tissue around about 1 gram is left around the tracheoesophageal groove to prevent injury to recurrent laryngeal nerves.
Is it in the tracheoesophageal? Okay, so it is on which side do you leave that 1 gram?
Sir, both the sides.
Then what is the difference between a subtotal thyroidectomy?
Sir, in subtotal thyroidectomy, around 8 gram of tissue is left on both the sides, sir.
Okay. Now, see,
In
there is confusion regarding total thyroidectomy and subtotal and near total thyroidectomy. If you read, say, Sadiston, and then it will be saying that on one side you do a complete removal. So, for example, this is probably, if you have said total thyroidectomy, that's okay, because you cannot, from a picture, you cannot tell us what is the status, but total thyroidectomy is a good answer. But even if you have said near total, which cannot be said from without looking at the patient side of the operation, if you leave around 1 gram of the tissue, now this is not very clear how much amount to be left. We have said 2 grams. It is around some amount of the tissue that is left to preserve the recurrent laryngeal and the parathyroid, practically.
Okay.
That is on the normal side. Say, for example, on this patient, maybe the left side. So that is the near total thyroidectomy. And in the times of particularly differentiated thyroid malignancies, this will be one of the types of surgeries in contrast to a total thyroidectomy that is always done for a medullary. Now, indications in benign conditions that require this operation. The indications in benign conditions, as we have said, will be in toxic and non-toxic goiter. Toxic goiters, as we have said, toxic multinodular and diffuse toxic or Graves. Non-toxic will be a multinodular goiter with compressive symptoms and or multinodular goiter with a rapidly enlarging nodule with a suspicion of a malignancy like a Bethesda 3, but it is in a multinodular goiter scenario. The third will be a diffuse goiter or a colloid goiter, so called as, with a compression on the trachea. So will be the indications of a total thyroidectomy. The last one will be even in a goiter with a retrosternal prolongation. Definitely it will be better to consider always a total thyroidectomy rather than considering a subtotal as a part of the procedure. Now, the next part that we have the next part that the question has asked you about is name to histological types associated with a poor prognosis. Now, doctor, this is in OSCEs. This chance will always be there because now you are a bit confused that how much I know many things, what will I say? Now, at this point, as you have very rightly said, you can talk about, to begin with, in the follicular cell lineage, can you tell me which is the cancer that arises from the follicular cell lineage that has the worst outcome possible? Follicular cell, can you tell me, sir, what is the cancer with the worst outcome?
Don't know.
Worst outcome is what? You said already.
Sir,
it is the follicular cell lineage, sir, not
arthal cell carcinoma previously thought to be a variant of follicular cell carcinoma and it has a worse prognosis, but now they classified arthal cell carcinoma separate base.
Okay, let me ask you the question in a different way, sir. Which is a thyroid cancer with the worst prognosis? The patient will die within 3 months.
Sir, anaplastic carcinoma.
What is the cell lineage of anaplastic?
Sir, poorly differentiated, dedifferentiated.
Yes, right. So it's a dedifferentiated carcinoma which arises from a follicular cell lineage and can arise either from a papillary or a follicular variant, and then can either de-differentiate or it will be a clump of undifferentiated cells which will be arising in this background. Okay, so this is the first one to know about, and you have very, very rightly mentioned about this one. Now, so this is the anaplastic. Now, the second type will be, if you talk about the differentiated lineage only, then comes the types of papillary to the follicular, and there are multiple variants which are associated with a definitely a bad prognosis. Can you tell me what are the histological types of bad varieties of differentiated thyroid cancers?
Sir, diffuse in papillary carcinoma, apart from classical papillary, the order of bad prognosis is diffuse worst prognosis compared to columnar, then tall, finally classical papillary carcinoma.
Okay,
From decreasing order of prognosis.
Or so I will be mentioning around 5. Please remember them.
Okay.
Number 1 is a tall cell variant, is a poor type of papillary. Insular variant is a poor type of papillary. Columnar variant, poor type of papillary. Diffuse sclerosing, poor type of papillary. Clear cell, poor type of papillary. And trabecular. So there are technically 6 types which are really bad. Okay. Last one. Can you tell me some types? And the next one we will always say is a medullary. Medullary is always associated with a bad prognosis given the nature of the metastasis and given that it is not radiosensitive. Okay. So this is all. Now, what is the additional structure removed? As sir has very, very appropriately said, for a Bethesda 5, if you are planning to do not a suspected malignancy, and if you see an enlargement of nodes in the central compartment, then it is important that you should remove the central compartment nodes, provided your center has a recurrent laryngeal nerve injury rates less than 0.5 and a parathyroid removal rates less than around 2%.
Okay.
So these are the structures, or forget about those. You should be saying at least a central compartment lymph nodes that should be removed. Yes, can you tell me the boundaries of dissection of a central compartment?
Sir, on the both the sides up to the interjugular vein, superiorly up to the cricothyroid notch, inferiorly sternal notch, sir.
I will not be very happy with till the anterior border of the internal jugular vein. It will be till the anterior border of the sternomastoid. Superiorly till the hyoid, but people do not go up to the hyoid. They go up to the thyroid cartilage, and inferiorly till the jugular notch. Okay? Right.
Yes, sir.
Okay.
I think that
one question. Now, genetic study is coming up for thyroid evaluation. You've done FNA.
Yes, sir.
What is the indication for doing genetic study in that particular situation?
Sir, methods are type 3 with the follicular neoplasm of unknown significance, ATP or ATP of unknown significance. We would try to do.
So what is that? What is that described as? One is benign, one is malignant on FNA, and third group in between is what? Is indeterminate.
Indeterminate.
So indeterminate, you need to do something. Name some genetic study which are important in thyroid evaluation.
Sir, PAX8, PPR alpha gamma, PPAR gamma, PAX8, sir.
What else? You are not talking about the commoner things.
Sir, BRAF V100,
yes.
V600E mutation
BRAF,
is
BRAF, red protoncogene, RAS, PAX8, and PPARY, gamma. Yes. Okay, so these are the important genetic studies. Okay, we can pass on to the next one.
Right.
Thank you, sir.
Thank you, sir.
Sir, has Dr. Kumar Gaurav joined us? Dr. Kumar Gaurav, if you're there, please unmute yourself. Dr. Bharat.
Why? Come on, yeah. Somebody should come. Don't
So
wait there.
can we have another volunteer from those who have joined us?
Sir, a patient under. Sir, good morning, sir.
Jyoti.
Good one.
Okay, fine. Please.
A
Please go ahead.
patient underwent laparoscopic cholecystectomy, which was converted to open surgery. Identify the probable pathology for which the conversion was done. Sir, I'm seeing the carcinoma gallbladder.
Absolutely right.
Gallbladder is cut open. And what do you look at inside?
The papillary growths like
Yeah. Yes. So wall is thickened.
wall is thickened.
And you find there is a proliferative lesion in the
Lumen of the gallbladder.
lumen of the gallbladder. So what is the likely cause for this conversion?
Sir, suspecting of malignancy and thickening of gallbladder, seeing that.
Okay.
Okay, right enough.
What is the next investigation after histological confirmation? Sir, after histology, I want to go with the CCT whole abdomen to know the any hepatic or peritoneal involvement.
Okay.
CCT is for what? Exactly. It's not.
Liver
Don't utter peritoneal involvement. Peritoneal
Liver
nodules are not picked up easily, but you talk of more important things. One
Liver
is
metastasis.
evaluation of primary,
Yes.
primary and metastatic disease. So what metastases are easily picked up on CT?
So lymph nodes and liver metastasis.
Yes, and large omental nodules, pelvic deposits, and the peritoneal nodules are larger than that you can pick up.
And what are the surgical boundary of dissection in the next operation done for the pathology at a later date? Sorry, depending on the histological feature, I mean involvement, extension of the tumor, I want to go
standard that you see the disease is
External
confined to the
cholecystectomy.
gallbladder. If the disease has extended beyond the gallbladder, you have distant node being involved, you will not proceed. You are proceeding for a standard radical cholecystectomy.
Yes.
What is the boundary of this?
So 2 centimeter margin of the liver tissue and the involvement of the pericortical lymph nodes, periportal lymph nodes, and biliary margin also.
What biliary margin?
And
Here
low
there's
part of the
common
cystic.
hepatic duct. Do you routinely remove common hepatic duct with the radical cholecystectomy?
No, sir.
When you will consider removing the bile duct?
When the malignancy is involving at the neck and
what is the indication for removing the bile duct while doing radical cholecystectomy? In which site of carcinoma it is required more commonly?
so neck
Where
of
in
the
the gallbladder? Yes. So neck of the gallbladder, their involvement of bile duct may be early. And while operating, you need to the cystic duct margin frozen.
Yes.
So how it guides?
See?
How it guides? If you've done a frozen section biopsy from the cystic duct stump, how it decides you proceed with the bile duct excision or not?
Sir, up to CBD margin also we have to check.
CBD margin you are not sending for frozen. You are sending from the cystic duct margin. So if the cystic duct margin is positive, you have to go for a bile duct.
Okay. Doctor, what is the extent of the nodal dissection that you will do if you are planning to do a radical cholecystectomy?
Sir, up to pancreatic.
Where do you begin and where do you end? Or what are the boundaries of the nodal dissection?
What is the first tier of node which drains gallbladder? First tier.
So pericortical and periportal.
Pericortical means around the bile duct. Periportal means
Portal. Hepatoduodenal ligament.
Yes. And what is the next tire?
And the celiac artery and SME.
Celiac artery is far off. Usually, celiac artery node is not taken with the radical specimen. What else you take? As you leave the duodenum and the pancreas?
Retropancreatic lymph nodes along the superior mesenteric artery.
Retroduodenal node.
Yes.
Okay. Right. Now, what are the contraindications of proceeding to a radical cholecystectomy after the histological confirmation is done? Or what are the findings on a CT scan that will tell you that you should not proceed to a radical cholecystectomy?
Sir, extensive hepatic involvement and if it is disseminated peritoneal mets and omental mets present.
Please continue, doctor. You are doing absolutely nice. Please continue. Number one are local unresectability.
Yes.
That means there can be residual disease on the trunk of the portal vein or hepatic artery that will make it unresectable. Number two, there is an extent of the liver infiltration that is unresectable. That means there are non-continuous metastasis in different segments which are not going to be resected. Remember that if it is a metastasis that is confined to the right side of the liver, even with a gallbladder cancer, which is now being clubbed with cholangiocancer, you can be aggressive and you can now even go for a central hepatectomy. Okay, but if it is to the other side of the liver, which is not within your boundaries of a central hepatectomy, you cannot be doing that. The next one will be a nodal metastasis that is beyond the confines of the dissection. Now, that is the reason you should know how much is the boundaries of dissection. Please remember that the lymphatics of the gallbladder, the first echelon will usually be the cystic duct, then the second echelon will be portal, and thereafter the pericholedochal till the right of the hepatic artery. Now, so that means your dissection is till the right of the hepatic artery or till the hepatic artery proper, and inferiorly you go up till the second part of duodenum with the retropancreatic lymph node. Then medially you go till the lymph node of the common hepatic artery and then stop. People will consider that the aortocaval lymph node is an indication of not doing a surgery because it indicates a metastatic disease. Okay.
Okay.
So these are the reasons about this, and we have not talked about distant metastasis like ascites, peritoneal nodules, omental nodules, pelvic deposits, lung nodules, etc. Right.
Okay.
I think, sir, we can now proceed to the next one. Okay. Okay. So it was a good discussion, doctor.
Next. Who is next? Come on, don't waste time.
So we.
Hello, good morning, sir. I'm Dr. Shumon. Hello, sir.
Yes, come on, please.
Sir, this is a 10-year-old underwent elective abdominal surgery for GI bleeding. Identify the specimen. Sir, this is a specimen of Meckel's diverticulum, showing the diverticulum along with a part of gut, small gut. And identify A, B, C. The part A is the tip of Meckel's diverticulum, B is the base of the diverticulum, and C is the mesentery.
Okay.
What are the complications in adult patients? So it can lead to the GI bleeding and it can lead to obstruction.
Good. If I ask one more.
The
If I ask one more.
interception.
Interception. Yes. Anything else at the base?
Volvul.
No. In the Barbi, you say the obstruction is one. And the base, what can happen? Any evidence of ulceration at the base?
Sir, gastric cell may heterotopically found over there, and that may lead to
So it will be a site of ectopic peptic ulcer. Ectopic peptic ulcer.
peptic ulcer.
Why a part of small gut is removed in the specimen?
So the base is from the specimen. It is evident that the base is broad, and for a broad base Meckel's diverticulum, generally a part of the which part of gut is taken out along with the mesentery.
No. Your statement should be very clear. It is not because of the base is broad you removed a wedge of small gut. In all cases, you have to remove a wedge of the small gut. Why? Why you need to remove a wedge of the small gut while you resect the Meckel's?
Sir, bleeding can be happen if wedge resection is done, sir. In case of diverticulitis, we can do if it contains ectopic mucosa, we want to do resection anastomosis.
No. You see, the idea is you are not looking at the peptic ulcer from outside. You may be doing a surgery for the infection or whatever the reason. You remove a wedge with a small gut because even if there is some peptic ulcer cells, the ulcer may occur at the base. So remove a wedge, assuming that there might be some ectopic gastric tissue in the base of the Meckel. That is the reason. What is the embryological origin of this pathology?
Remnant of intestinal duct.
This is what? Embryologically?
Remnant of intestinal duct.
Which part? Which remnant? VID is a long tract.
Proximal part of the
This is a persistent proximal part of VID. Okay. What will happen if the distal part of the VID remains and proximal part disappears? Distal part of VID is there, the proximal part has disappeared. What is that condition?
The umbilical sinus.
There will
What
be
is that? That produces a
urethral cyst.
something protruding from the umbilicus, which appears red.
Urethral cyst.
Umbilical granuloma.
That is known as a raspberry tumor. Okay. Why this patient may have obstruction?
So when the proximal part remains and the distal part becomes a band, the band may lead to which can lead to obstruction.
Yeah.
Because
So
of the presence
there may be rotation of gut around this band.
around the band.
So it may be a whole thing is bland. The whole cord is becoming a band-like structure, or proximal part remain as a Meckel's, and from Meckel's tip to the parietes there may be a band, and small gut can rotate around this band. Okay. Ramanuj, any other point?
So the number one point is that why does an intestinal obstruction occur? As you have mentioned, this is a band. Number one, can you mention any other causes of intestinal obstruction beyond the band?
Sir, it can act
Number
as a
two,
lead point for
lead point of intersusception. Number three, there is an internal herniation between the arterial supply of the Meckel, something called as the vitelline artery or the vitellomesenteric band, and the Meckel. This is an uncommon scenario, but if you have seen, this is one of the internal herniation. That means, where is the blood supply of the Meckel's diverticulum coming from? Where is the blood supply of the Meckel diverticulum coming from?
So the mesentery.
No, sir. This is the difference, sir. The blood supply of the Meckel is not derived from the same ileal mesentery. There is a dedicated blood supply from the SMA, which will act somewhat like an appendix arterial supply, and thus it will be technically and band called as the vitellomesenteric or the vitelline artery, and this arterial supply will be directly supplying to the Meckel. Now, in between the Meckel and the arterial supply band, there will be a space in which a bowel can enter, small bowel can enter, and thus producing a internal herniation. The next cause can be a growth that arises in the base of the Meckel diverticulum, particularly a neuroendocrine malignancy can arise in the base of the Meckel diverticulum. Okay, right. So you have mentioned. Now, the next part of this is that, as you have said, you have always said about the complications in an adult, right? Now, tell me that how does the surgery differ if you get an asymptomatic Meckel during an operation versus a bleeding Meckel in a child or an adult?
Sir,
You are opting for something else. Incidental finding of Meckels. What is the strategy?
in case of incidental diverticulum, if it is not making any symptom, but the base is broad, and there is no chance of no sign of inflammation and nothing, then we will not do any operative measurement over there. But if it is bleeding, then we will go for operative measures.
No, sir, you did not understand the question. The question is, you have got an asymptomatic Meckel and you decide to take out the Meckel. We'll be coming out to the next question on when do you take out an asymptomatic Meckel. The question is not that. The question is, you decide to take out an asymptomatic Meckel. Okay. How is that operation different from the one that is shown in the specimen? This is the resection of the bowel, a segmental resection of the small intestine. For an asymptomatic Meckel, what is the operation that you usually plan for? Do you do this usually?
V-shaped diverticulum.
Diverticulectomy.
So usually you do a diverticulectomy only. Now, as sir has very appropriately said, this is segmental resection because in a bleeding Meckel you get an ulcer on the antimesenteric side, and the ulcer on the antimesenteric side bleeds. Hence, you must take out the surrounding intestine along with that one. The last question, and I think we have Professor Shukumar Maiti also here. So, what are the indications about removal of an asymptomatic Meckel's diverticulum?
Sir, age less than 40, narrow base, when the long Meckels.
Okay. Anyone with any more ideas, please?
Sir?
Okay. See, number one is the age of the patient, in which definitely 40, maybe many people will say 40, many people will say, no, it is around 35 or 30s. And beyond that, you should think about, or before that, you should think about taking out the Meckel. Though this is still controversial and the controversy has not been resolved. Number two, the length of the Meckel more than 2. Number 3, the base of the Meckel, again, there is a controversy about narrow and broad. People consider it removing in the narrow base. Number 4, thickening in any part of the Meckel, which can be suggestive of an abnormal tissue. Number 5, a palpable ulcer. Number 6, multiple lymph nodes in the surrounding mesentery. Okay. So these are the scenarios in a Meckel that will require you to remove them. Sir, I will request Sir, any other points to know about in this asymptomatic technique?
I think for specimen, you see, this is a very specimen wise, we have covered everything.
Right.
We are not going to the presentation and others.
Right. Okay. So with this, I think, sir, we can go to the next one now.
Yeah.
Sir, has Dr. Paritosh joined us? If he could please unmute.
Yes, sir. Good morning, sir.
Yeah.
Sir, this is a linear, identify the instrument. This is a linear intestinal stapler.
No, correct your answer. It's not linear intestinal stapler. You have to mention number of things here. Identify the instrument is a complete answer. It's not a stapler. What is it exactly? Yesterday there was a long ASI class. I forwarded you. It was fantastic class yesterday night. Don't miss this class. Keep your time free on all Wednesdays between 9 p.m. to 11 p.m. ASI will have fantastic academic session. Yesterday they have discussed the suture materials, needles, staplers for open and laparoscopic surgery. So what is this? This is not only stapler. This is a linear cutter, number one. And second is you have to say that this blade is having a variable length. So it will be there in the instrument itself written what is the centimeter of this instrument. So you have to mention that this is a 60 millimeter linear cutter. Okay, don't say stapler. Stapler only staples. Cutter, staples, and cut. Both.
Sir, any two elective upper GI surgery that you have seen this device?
Yes. Say the operation you have seen, or you have not seen. You have to.
Sir, I have seen mostly in cases of a small intestine or large intestine surgeries, the resection anastomosis. Like I have not seen upper GI surgery in which this stapler has been used.
If you're asked about the upper GI surgery, then you stick to upper GI surgery.
Sir, this is having a blue cartilage, so that's why, sir. Like
cartilage you can change. Cartilage you can change. That is not a point. The question is, this instrument is used for a linear cutting device.
Yes, sir. In gastrectomy, it can be used.
Simple answer. Upper GI stomach.
Yes, sir.
Is it during gastrectomy? Can you use this instrument during gastrectomy?
Yes, sir. Yes, sir.
Can you use it for gastrojejunostomy?
Yes, sir. Yes, sir.
So, you use it for fashioning a rule loop?
Yes, sir.
So, you're asked to mention any two, no problem at all.
Sir.
Next point was?
Sir, mention any two complication of this device used in GI surgery.
Yeah.
Sir, one might be a bleeding. And the other might be, sir, a leak, the anastomotic leak. No, the leak from the cut side, that the distal or proximal cut side.
Hello. Now, when you are mentioning complications, doctor, see, leak, well, you may say leak is a complication, but definitely it will not be wrong to say leak. But can you mention any immediate intraoperative complication that you have seen with this device? Number one, when there is a staple line misfire, what are the problems with a staple line misfire?
Sir, there won't be proper cutting,
okay,
or stapling if
okay,
if it misfires.
So number one, there is a bleeding from the cut edge, which is an active bleed. Number two, there can be only a cutting that has happened on the mucosa, but there is no staple line formation, or there is a partial staple line formation. Okay. Number three, the most dangerous one that we all fear is the stapler getting stuck, and you cannot open the stapler. That's a bad one, but well, it can happen. Next one is that whenever you do a stapling, always remember before you fire the stapler, what is the most important thing that you must check before you fire the stapler? Before you fire the stapler, what is the last check that you always do?
So we wait for around.
You wait for 30 seconds. That is
Yes,
done.
sir.
Before you fire the stapler, what is the final check that you always do?
So the bowel should the bowel that we are going to staple and cut should be in between the range of the firing of the staplers.
That means you are trying to say that I will like to see if there is no additional tissue beyond the structure that is to be fired. If you are creating a Roux-en-Y loop, you should not have a piece of momentum between the stapler blades. If you are transecting the duodenum, you should not have the bile duct in your staple line. Okay, and this is a very important advice. Please remember that throughout. Whenever you fire an open or a lap stapler, be sure to see what you are firing, because there is a parallax error and many times we have had injuries. Okay. The last will be delayed complications, where remember that stapler lines can sometimes, like an anastomotic line, lead to stricture. How do you sterilize this instrument, sir?
Sir, it is sterilized by autoclaving.
Okay, this is now a trick question. Whenever you talk about sterilization, these are usually single sterile devices. Okay, so these are usually devices which are of single uses. So please remember that.
The cartilage, sir, the cartilage or the whole of the stapler, sir?
No, the whole of the stapler. Now it has not been shown. This is not a full metal stapler. Full metal staplers are reusable stapler. They are autoclavable. This kind of a device is ideally not a reusable stapler. This is a one-use stapler and you should discard it. But yes, what we do is that we usually sterilize this not by autoclaving, either by a plasma sterilization or even by a chemical sterilization with glutaraldehyde, and then use it for our purpose by changing the cartridge. Okay. So usually in a cost constrained environment, we do that, but ideally this should be a disposable stapler. Okay, right.
Okay, we have blue, green, white cartridge. What is the idea of different types of cartridge? What decides about the change in color?
Yes, sir. Which color we use where? That is what
I'm asking for. These cartridge are different in what respect? You use in different situations, I agree. But what I am asking is, what is the difference between a blue, white, and green cartridge?
I don't know, sir.
Thickness of the tissue.
This is what?
White.
Yes, this is the staple height. Staple height, you see. This all again depends on the what tissue are using it. Okay, if it's a thicker tissue, you need a longer staple height. So based on the staple height, okay, when it's 10 to 15 millimeter, this is a blue cartridge. Okay, in a green cartridge, it is thicker, wider staple height. Okay. Okay, next one. Next. And I have another question in the staple. Suppose you have a 65 millimeter cartridge. You fire. How much it will cut? How much it will staple?
Sir, it will staple 65 mm, but it will cut 2 millimeter less on either side.
Very good. So it will cut 2 mm less on either side. So 61 millimeter will be the opening,
Sir.
anastomotic opening, and
Sir.
you staple 65 millimeter. That's good. Okay. Next.
Thank you, sir.
Sir, sir, can I take this question, sir?
Yes, yes. Milind.
Yes, sir. Sir, identify the instrument. So this is a two-way Foley's catheter. Any two emergency uses for this device?
Foley's catheter is not the right complete answer. You try to look at the margin. There you will find the size of the catheter. There you will find the balloon capacity. If you can see clearly, you should see that. If it's not clearly seen, you can skip.
So 16 French Foley's two-way Foley's catheter, sir. So balloon capacity, I'm not sure about, sir.
It is written there. If you can see, you read out. If you cannot see, you can say that it's not seen. The balloon capacity is how much. Okay. So
Okay.
most of the time, the size and the balloon capacity is the same place. Okay.
Yes, sir. So two emergency uses for this device. One for acute in case of acute retention of urine, and so second, can be used for atonic PPH, sir. And sir mentioned two complications of this device on long-term use, sir, infection and blockage. Sir.
Dr. Ramanuj. This balloon is inflated how?
So, it is inflated by pushing normal saline through the.
So the balloon capacity is 30 to 50 ml.
Yes,
while
sir.
catheterizing in under normal circumstances, how much saline you push?
So around 20 cc, sir.
Why 20?
So if it's
you see,
sir?
it's a balloon capacity mentioned when you need to inflate the balloon for some other reason. A simple 10 ml inflation is good enough for retention. Okay. When you need a larger inflation of this balloon, in what circumstances?
Sir, if you're using for the balloon for compression, sir, compression of bleeding.
So if you had done a earlier open prostatectomy, where I need to apply pressure on the prostatic bed. So this catheter is placed in a bed and then inflate the balloon so that it causes compression of the prostatic bed. Okay. Ramanuj, any question?
Right. Next one is that, okay, so number one emergency use that you have mentioned is
acute retention of urine.
Number two?
So atonic PPH, sir.
Do not get your answer, sir.
Sir, atonic PPH, sir.
Atonic PPH is not an correct answer with this one, sir. In an atonic PPH, you do not use a Foley's catheter, you use a balloon called a Mukherjee balloon, BAKRI. This is not the device for an atonic PPH.
Okay, sir.
Come on, man, talk about urology, other uses.
Sir, nephrostomy, sir. I'm not sure, sir. Emergency use, I'm not sure.
Okay. Okay, so number is trauma. Oh, very good. Is that in trauma, sir, please mention the specific answer, because remember that the examiner is wanting a particular specific answer. In trauma or in shock patient, what are you trying to do with this device?
So, prevention of hemorrhage, sir.
Prevention of hemorrhage from which part?
Sir, from the urethra, sir.
No, sir. You are going away. So let me be very clear about the indications of a Foley catheter. Okay. So this may look like an undergraduate answer, but it is not. Foley's catheter, please remember, has three groups of uses. Number one is in urology. Number two, other uses beyond urology. Number 3, general uses. When you talk about general uses of a Foley's catheter, number 1 is it is used for measuring the urine output either intraoperatively or in patients with hypovolemia, where you are giving a fluid and you need to measure the amount of urine output to measure the adequacy of your resuscitation. That means you want to measure the urine output, very bluntly put. Number 1. Number 2, the other general use of a Foley's catheter is to differentiate between anuria and retention urine. This is a very silly answer that I do not like, but there are many examiners who may like this answer, to differentiate between an anuria and a retention. Number 3, this can be used in some patients who are unconscious, either due to head injury or due to maybe spinal injury, to prevent urine being contaminated or an overflow incontinence producing difficulties to the patient. So I can remember at least 3 general uses of a Foley's catheter. Now, when you talk about uses in urology, talk about emergency uses in urology that begins with acute retention urine. Number 2 is suprapubic cystostomy can be done with this one. Number 3, in a case of an infected hydronephrosis, you can use this for doing a percutaneous or an open nephrostomy. Percutaneous will not be the right answer. A open nephrostomy with a Foley's catheter. Okay. The next one will be in an elective urology setting. If you are doing a TURP, you do not need the balloon inflated to a larger volume, but some people still do that. But if you are doing an open prostatectomy, particularly a Freyr's prostatectomy, it is mandatory that you should have a 3-way Foley catheter, not this one, in which the balloon is inflated in the bed and you give a tongue at the neck of the bladder to produce a hemostasis. Beyond this, please remember, in the urology, some people will still do a nephrostomy if they're operating on a hydronephrosis, and if they feel the creatinine, the GFR is pretty low. So there was an old school of doing an open nephrostomy. Now, can you mention any GI uses of a Foley's catheter?
Sir, cholecystostomy.
Cholecystostomy is a good answer, sir. Any other GI uses?
Feeding jejunostomy, sir.
It can be a feeding gastrostomy. Okay. Anything in the jejunum?
Feeding jejunostomy, sir.
Very good. Right. Now see how many uses you are saying now. Anything in the cecum?
Sir, cecostomy.
Okay. Anything to do with an emergency appendix in an intestinal obstruction? This has been an old
On-table
favorite.
lavage.
This is an on-table colonic lavage. Very good. Okay. Anything to do with the rectum and this device? Now you are mentioning about a tamponade of a bleeding, not usually in PPH, but in a case of a rectal bleed with a carcinoma in the lower rectum, if you can negotiate the balloon above the cancer and give an inflation and pull it out, this is a temporary situation of a tamponade. Okay, but then you need to consider a direct division and control of the bleed. So these are the indications that I can remember. There can be many more indications that the more you think of. But these are the indications of use of a Foley's catheter. Okay. What are the contraindications of this device to be used in an emergency? When will you not use a Foley's catheter?
Sir, urethral injury.
Okay. Why will you not use a Foley's catheter, sir?
Sir, because if there is disruption of the urethra, then we might create a false passage using Foley's catheter.
Very good.
So what should be done? What should be done before you try a catheterization attempt? What you should do in a suspected urethral injury before you attempt catheterization? Because partial injury, catheter is advisable. What investigation will do before you attempt catheterization in urethral injury?
So, intravenous urography.
Retrograde urography.
Retrograde.
Retrograde urography. Sorry, sir.
Yes. So do a retrograde urethrogram. So if you find that contrast is going to the bladder is a partial urethral rupture, you can do gentle catheterization, or alternatively, you should do a suprapubic. Let this is, you may not do a urethral catheterization in this situation. Okay, so don't attempt catheterization in a suspected urethral injury. We can pass on the next one.
Right. So, no,
Yeah.
sir, many to complications on a long-term use. Yes, please tell me that one.
I say
Infection and blockage.
Where is the infection, sir?
Sir, urinary, sir, infection, just urinary tract infections.
Okay, so number one is a urinary tract infection. Number two,
So, sir, on chronic, on long-term use, it can get blocked, so the catheter can get blocked. So.
anything else can happen at the tip of the catheter.
at the tip of the catheter, long-term use comes as an X-ray, comes in your specimen.
Bladder calculi.
Very good. What is the type of calculi, sir, that will happen? What is the nature of the calculi that is going to happen, sir, in the bladder? Is it a primary calculi or is it a secondary calculi?
Sir, secondary calculi, sir.
Okay, what is the chemical composition?
Sir.
This is usually a triple phosphate.
Sir.
Remember, over foreign bodies, the bladder has a prone to dispose triple phosphate stones. Last question is, if there is a catheter stone, how do you plan to take that stone out? In the era of endourology, how do you plan to take a Foley's catheter stone out? Well, this is a trick question, sir. You always do an open suprapubic lithotomy and then take out the stone. You cannot do it by an endourology. Okay? And lastly, please remember, long-standing catheters can lead to urethral strictures and periurethral abscess. Catheter should not be very tight, should not be very loose. It is better to have a loose catheter rather than a tight catheter. Always remember, tight catheters produce periurethral abscess formations and fistulas. Okay, I think we can move to the next one now. The last question, I think.
Last.
Dr. Bharat has joined us. Dr. Bharat.
Good morning, sir.
Good morning.
Yeah.
Sir, this instruments I'm Fogarty catheter.
Fogarty balloon catheter.
Balloon catheter. The emergency use for this is used to remove the clots in the blood vessels, sir.
So it is for therapeutic
Removing
embolectomy.
the embolectomy.
Yes.
Mention any uses in GA surgery in during the CBD exploration. In the CBD stone, we can use to remove the stones from the CBD, sir.
Absolutely right, sir. Absolutely right. Now, very well said. Just a few discussions to complete the lecture. We have said about embolectomy in an emergency situation. What is the clinical scenario that requires you to do an embolectomy in an emergency surgery setting?
The patient has to be present within the ischemic time before the
disease condition, sir, which we consider an embolectomy.
So it has to be acute emboli.
It has to be an acute limb ischemia.
Acute limb.
Right. So there are three causes of acute limb ischemia: an acute embolism, an acute thrombosis, and an acute trauma. Which one will you consider for an embolectomy?
Acute limb ischemia and then trauma, sir.
Okay, which one will you consider? There are three causes of an acute limb ischemia. Which one needs an embolectomy? Number one is an acute embolus. Yes, it needs. Does a thrombosis need an acute embolectomy? Or the answer is yes, it should be, because an embolus can also have, and thrombus can also dislodge and go as an embolus. And definitely trauma should always have an embolectomy that should be done. The next question, doctor, is that which side do you do the embolectomy first?
Sir, puncture site has to be opposite side of the embolus, sir.
No, sir. The question was not that. The question was that which side do you do the embolectomy first? Do you do the embolectomy on the distal? Say, for example, there has been an injury in the femoral artery. I'll give you a technical example. And then you have repaired or you are planning to repair that. The only question is that before you release the clamp, you are trying to do the embolectomy. Now,
Okay,
which
sir.
side will you do the embolectomy first? Say towards the popliteal side or towards the iliac side?
Sir, towards the iliac side first, sir.
Well, iliac side, because iliac does not have any clots, but yes, people do it that because at the site of trauma or thrombosis, there can be a clot and that can go distally. So you will do that towards the iliac side, put a clamp, and then take the distal embolectomy, take out the clot, then consider
discharge and go.
Right. The last question, sir, is after a successful embolectomy, how do you know that the limb perfusion is adequate?
We can
What should happen
go
on
with the
tipping?
check angiogram. We can check with
Before
the
angiogram?
perfusion.
Before angiogram? On
Sir,
tipping?
Peripheral pulse.
there will be
Clinically
change in the color of the limb, sir.
Peripheral pulses.
Sir, maintain a sequence. What is the first thing that a surgeon will tell? And he may tell his assistants to open one of his gloves and check something.
Sir,
Bleeding, peripheral pulse, bleeding from the tip.
Number one is the temperature of the limb. Okay. Number two is the capillary refill.
Refilling.
What is the normal capillary refill time, sir?
Less than 2 seconds, sir.
Less than 3 seconds, sir. 2 seconds. Number three is the appearance of the pulse. Okay. Right. Number fourth is at the end of the operation, do you have any instruments to detect that there has been an adequate perfusion at the bedside, or a very simple operation instrument?
Handheld Doppler we can use to check the.
Sir, I do not have an handheld Doppler in my theater. I have to borrow it from my plastic surgeon colleague. Something that an anesthesiologist is using.
So pulse oximeter to check the saturation of the dose.
Pulse oximeter, isn't it? Okay. How do you know that your pulse oximeter readings are adequate?
So check with the opposite limb.
Very nice. So this is exactly the trick question. You check it with the opposite limb. Okay. And then if there is a questionable vascularity, say you have done an embolectomy between 4 to 6 hours. What is the additional surgery that you shall do in this patient beyond revascularization?
Metal stent to at the site of thrombotic.
Sir, you did not question. So my question is, you have done a revascularization. Okay. You have done successful revascularization. Vascular repair is good. But the patient came to you after 4 hours, within 6 hours. What is the additional procedure that you should do in a lower
thrombolysis? Not sure about that. Thrombolysis. Thrombolysis first.
Done, sir. The limb is now warm. Capillary refill is good. What is the danger that this patient can have after
reperfusion ischemia to prevent
yes, I know that. What is the additional procedure that you will do? Anyone, please?
I don't know, sir.
Okay. Anyone who is listening to this? When will you like to do a fasciotomy?
If the compartment of the involved limb is very tense.
Right, sir. This is a scenario where if you talk to your vascular colleagues, they will say that if there has been more than 4 hours of ischemia, this kind of tissues are more prone to develop reperfusion injuries. So, to be on the safer side, they will always advise to go for a prophylactic fasciotomy rather than appear for the compartment syndrome to happen and then do a fasciotomy. Okay? I think that we had an extensive discussion. And GI, you have already said.
Thank you. Thank you, Ramanuj. Any comments from anybody? Any comment? Dr. Maiti?
excellent discussion. Nice.
Thank you, sir.
Any question from anybody else?
Sir, I have a question. Sir, in the first image, when we had seen the gallbladder, so from the external side, what will we say? The gallbladder appeared to be thickened wall and like the appearance.
No, it was the gallbladder is cut open. You see, it was cut open, showing the growth.
So intraoperatively, I'm converting from laparoscopic to open. So will I say it was difficult scale? That's why I opened, or sir, like
if you find that wall is not pink, you find wall is thick, you cannot hold the wall appears nodular, you have suspicion of malignancy. Don't loiter, open up.
Okay, sir.
Or you close.
Professor Saha,
Yes.
Professor Saha, regarding Foley's catheter, the material of the Foley's, that should also be mentioned when answering.
Yeah, now you have both silastic and latex Foley's catheter. What is the advantage of silastic over latex material? Silastic is very costly, but in some circumstances,
for prolonged duration, sir.
yes. So silastic is less irritant, and you can keep this patient. Some patient who are neurogenic bladder, patient with spinal injuries, may require long-term catheterization. So in that case, you can have silastic Foley's catheter, and the standard material that is coming up for day-to-day use is a latex, not rubber.
Another tricky question. All of us are aware of it. That may be said during answering. That is a problem with Foley's is the non-deflation of the Foley's balloon. If it is there, the balloon may not deflate. What are the different ways to deflate the balloon for the removal of the Foley's catheter? Any student can answer? Any trainee can answer?
You cannot deflate the balloon. What to do?
Sir,
So
we can
USG guided
cut we can cut the side from where we will inflate. We normally inflate the balloon. We can cut that side to remove the sphincter action to valve action.
Also, nothing happened.
Sir, never ever do that. And I will tell you what happens.
Never cut the as a first step.
Never cut the catheter, because do you know what happens? The proximal end goes back to the bladder.
No, not catheter, sir. The valve action from where we normally inflate the balloon.
Okay, right.
Even the bulb cutting is not the first thing you do.
Sir, we'll do a DRE and we'll inflate the balloon. We'll do the DRE and suprapubic will puncture the balloon if it is palpable. No, not suprapubically, sir.
Percutaneous
Ultrasound guided
percutaneous puncture.
Okay, very good answer. That is the best way. If you have the facility of ultrasound, that will help you to puncture the balloon with a needle. That is the best answer. But if USG is not available, then alternate ways, what you have mentioned, that place your finger in the rectum, push the bladder forward, and just blindly introduce a very fine needle suprapubic way, and that can suddenly puncture. By perchance, that can puncture. Sometimes if you make a ballotability, the balloon may come forward, that may float, and that becomes easy to puncture the balloon. Another way that is usually not followed, but in our HS days and house club period and also the PG period, we have done in some of the cases, we have introduced the ether. But ether sometimes causes some irritation of the bladder, but a very small amount, only a few drops of ether introduced per your channel, side channel, that causes the rupture of the balloon with a sound. You can also appreciate the sound from outside, and that is another way.
But sir, that will cause you the cystitis.
Absolutely.
After the patient will pass urine, that is small amount of ether. That is so, for that reason, for that theoretical reason, it is now avoided. But that is another way. You should know it. And other process sometimes tried introducing a very narrow your metal thread. Sometimes the wire of the electric, that is the copper wire of the electric wire, which is used and introduced through the side channel. That sometimes that is a theoretical. Most important thing is the puncturing needle, USG guided, sometimes blind puncture, and ether is the third option.
Thank you all. So we have a good discussion. It's not over, but we may continue subsequent session also for a few more. These are all representative presentation. You see, these are the way how a OSCE question comes to you. And as I already said, that you should be very specific, stick to the question that is being asked. Don't answer something else which are not required. You will not get marks because the examiner already has set answer in this particular question. Okay. Thank you, Milind.
আচ্ছা আরেকটা কোশ্চেন করছি any student can answer. What are the things named after Meckel? Meckel's diverticulum বললে any other thing named after Meckel?
Meckel's.
What is Meckel's cartilage or Meckel's ligament? Those are the remnant of the second arch. Okay, the second arch development, second arch cartilage which give rise to the development of styloid process, that is the Meckel's cartilage, and the stylohyoid ligament is also known as Meckel's ligament because that is derived from the perichondrial sheath of that Meckel's cartilage.
I was not knowing that.
Sir, there is something called as Meckel's cave. Okay, for the Gesserian ganglion, there is a Meckel's. I forgot the syndrome because these are all our quiz questions.
Another question I was asked during my exam, in a exam, what is Merkel? Merkel and Meckel. Merkel disc is a skin receptor, and that is close similarity with Meckel's and Merkel. Merkel disc is a skin sensory proprioceptive sensation receptor.
Absolutely.
Receptors.
Merkel cell carcinomas have become very important in the present times because these are one among the most fast rising skin cancers. So definitely bears a resemblance. Definitely, sir.
Base of the Meckel's diverticulum, in addition to the gastric tissue, sometimes it also lodges pancreatic tissue. So the inflammation of the gastric tissue may lead to ulceration. Similarly, the pancreatic tissue at the base of the Meckel's diverticulum can cause local pancreatitis, leading to the inflammation and ulcer formation. Okay, thank you. And liters hernia, you should remember.
Absolutely.
Okay, thank you. Very nice. Ramanuj, congratulations again for the brilliant presentation yesterday. And you have really raised the flag from West Bengal. I was feeling proud.
Sir, if required, then I will post that presentation then.
Yes, please. Excellent.
Sure.
Super.
Place in DNB group also, Ramanuj.
Yes, sir, definitely, sir. I'll be giving you the presentation.
Yeah. Thank you.
Okay. Thank you, sir. Thank you.
Thank you, Milind.
Thank you, sir.
Thank you.